Hello and welcome to today's ACPA team approval information session. My name is Erin Brenneman, and I am the staff liaison for the Commission on Approval of Teams, and I manage the team approval process. Tonight, I'd like to introduce you to Ari Rabkin, who is our new chair-elect for the Commission on Approval of Teams.
Thank you, Aaron. Thank you all for joining us today. As Aaron mentioned, I'm the chair-elect of the Commission on the Approval of Teams. I've been a member of the commission since 2024 as the Psychology and Social Work Representative, and again was recently selected by the commission and approved by the Board of ACPA to serve 1 year as the chair-elect, followed by 3 years as the chair of the Commission on Approval of Teams. In today's information session, we're going to be talking about the purpose and benefits of team approval. We're going to go through the standards as well as provide some updates on new information in the application process, as well as some new areas that are in the application. As we go through, please enter any questions that you might have in either the chat or the Q&A, and we will answer those at the end. We just ask that you keep your questions general and not specific to your team. If you do have a specific question about your team, there is an email to contact Aaron in the national office towards the end of the information session. So ACAP approved teams really demonstrate the vision and mission of ACPA. And so our vision really is to lead interdisciplinary cleft and craniofacial care so that patients and families thrive. And the mission or our values are really to empower and support cleft and craniofacial healthcare professionals and the patients they serve through research, education, and advocacy. We promote team care and professional collaboration to ensure the highest quality resources are available to all individuals with craniofacial differences throughout their healthcare journey. Cleft and craniofacial teams are comprised of experienced and qualified professionals from medical, surgical, dental, and allied health disciplines that are working together in an interdisciplinary and coordinated system. The purpose and goal of team care is to ensure that timely, evidence-based care is provided in a coordinated and consistent manner with the proper sequencing of evaluations and treatments within the framework of a patient's overall developmental, medical, and psychosocial needs. So ACPA developed the approval process for teams in order to provide standards that identify essential characteristics of quality for team composition and functioning in the context of a collaborating healthcare system in order to facilitate the improvement of team care. Also, as well as to provide accurate information to patients and families and caregivers regarding services provided by those teams that meet the specified standards. These standards are based on the ACA parameters of care, which have received widespread peer review and represent the expectations for approval of teams providing care to individuals with cleft and craniofacial differences. We always note that team approval is a voluntary and non-exclusionary process. There's no judgment or statement made about the quality of established teams that have not been selected to apply for approval, nor is holding approval required in order for healthcare professionals to organize or advertise themselves as a team. However, teams that do choose to undergo this external evaluation and demonstrate compliance with the standards for team care will be listed as ACPA-approved teams. ACPA-approved teams are listed on the website and are also available for the general public to reference when choosing a provider for their cleft and craniofacial healthcare needs. So why become an ACPA-approved team? Well, it can improve quality outcomes, it can support patient satisfaction, as well as demonstrate a commitment to ongoing improvement. It can also increase your institutional reputation, and it may support insurance company requests for treatment. Some other benefits of ACPA team approval include the listing on the ACPA website, the option to list your approval status in marketing or communication materials for your team. You receive a certificate recognizing your status as an ACPA approved team, as well as access to ACPA approved team table tents, the ACPA team approval logo, as well as toolkits that are provided once you are approved. The ACP Commission on Approval of Teams uses 7 standards that guide teams in providing quality care for cleft palate and craniofacial patients. The information in your application is really the only information that the Commission sees in the approval process. They don't review your website, they don't review other materials. So really the application, which we're going to be talking about today, is really what drives that approval process. So the standards for approval were updated in 2026, and there are now 7 standards that comprise the standards for approval. They're team composition, team management and responsibilities, patient and family caregiver communication, transition and adult care, social drivers of health, psychological and social services, and outcomes assessment. You can scan the code here to access the full standards document. You'll notice that Standard 4 is a new standard. So for teams who have previously applied for team approval, you now have a new standard, which is transition and adult care. The other areas have been updated based on the recent parameters of care, but the titles or areas remain the same. As I mentioned earlier, the standards for approval are based off of ACA's parameters of care that were updated in 2024. Those parameters were driven by evidence-based research, including numerous studies published in CPCJ. The ACPA parameters provide a framework for care delivery, which, in conjunction with your local standards, regulations, policies, or procedures, help inform high-quality care. So it's highly recommended that all craniofacial teams review the parameters of care and provide those parameters of care to the folks in your institution that are providing care for cleft and craniofacial patients. Again, you can scan the QR code here to access the updated parameters of care. The Commission on Approval of Teams is responsible for overseeing compliance with the standards for approval. Starting on July 1st of this year, the Commission will consist of 21 medical professionals representing cleft lip and palate surgery, orthodontics, speech-language pathology, psychology and social work, team coordination, craniofacial care, as well as other medical professionals, and 2 public members. They are responsible for overseeing the team approval process, as well as recognizing ACPA-approved teams. One thing I want to emphasize is that while most of the commission is made up of active members of ACPA and approved teams, it also includes individuals with lived experiences, as well as public members, some of whom may not be members of a cleft or craniofacial team. So it's important in your application to really avoid or spell out acronyms and be very specific about what your team does that meets the standards of care. Try to avoid idiosyncratic language or jargon, as specific words, phrases, or acronyms that are used by your team may have a specific meaning within your team that may not be recognized or understood or immediately clear to the commission. So again, really be careful to spell out the information that you're putting in your application to help the commission understand how you are meeting the standards of care. Again, I said this earlier, the written application is the only thing that the commission reviews. So if something is unclear or we don't understand what your team does, we may not be able to approve your team or we may request additional information. Again, keep in mind to use clear, simple language and try to avoid those acronyms or jargon words that may not be understood by somebody outside of your team. So now I want to move into talking a little bit more about the 2026 team approval application. We'll go over some of the guidelines, the application overview, and the submission process. Towards the end of this presentation, there is a QR code that links to the sample application that is available on the ACPA website. That does include some of the specific examples of how you might answer questions in your application, which I'll be discussing today as I go over the specific standards. Again, when you're preparing your application, you should refer to the newly updated standards for approval, not the previous standards of approval, so the ones that were approved in 2026. Be sure that all of your responses are in English with proper grammar and spelling, and make sure to use patient first language. Only completed applications will be accepted and reviewed. For the questions that require an essay response, there is a maximum of 500 words for each of those sections. We do encourage you to have multiple people on your team review the materials, provide edits, and again, make sure to spell check or grammar check that information. Again, completing the application should be a team effort. Make sure that the team leader, team coordinator, as well as your core specialties review the application before submitting. We also recommend that you download a copy of the entire submission and keep it on file so that you can look back at it later. For those of you that have previously completed the application, there is an area where we ask you to upload some medical records. For those individuals who are maybe applying for the first time, know that there will be a section that asks you to upload some team reports that have occurred from within the last 3 years. Remember to comply with HIPAA regulations and omit all patient identifying information. So that would include patient or family names, patient and family contact information, patient ID numbers or medical record numbers, birth dates, month or days of visits or surgeries, schools, as well as photos. It is okay to include a specific year for surgeries or visits, but again, make sure to redact or mark out the date and the month and the day of those surgeries, as well as birth dates. Any applications that do contain PHI will be returned for redactions. And if your application is returned a second time, there is a $125 penalty that will be due upon resubmission. Remember to only submit the pertinent medical record pages and not the entire medical history. To start the application, go to acpa.smapply.org. You can either log in or create a new account. For teams that have previously applied, you should already have an account. And for teams that are applying new, you'll have to create a new account. When creating your application, be sure to use your team's full name, okay? As I mentioned, there is a sample application that is posted on the ACPA website that provides some example answers, which I'll be reviewing today in the presentation. So now we're going to switch gears and talk a little bit about the specific standards and the questions that are asked as part of the application process. The first section is Standard 1, where you're identifying the team information, including your listing, your ID, your application type, and your listing information. Your application ID is not the same as your team ID. If you're unsure of your team's ID at the ACPA office, please contact teams@acpacares.org. It's important to select the correct option for the type of approval that your team is applying for. This will either be as a cleft palate team only, a craniofacial team only, or a cross-specialty team, meaning both cleft palate and craniofacial. The commission will only review the team for the type that you've selected. If you don't select the correct option, you will not get all the questions that are required to complete for that specific application type. Finally, in the team listing information, the team listing information will be used for the team's public listing on the ACPA's website, so make sure that your information is accurate. The first section of Standard 1 asks you to identify your lead team members. The team includes a designated patient care coordinator to facilitate the function and efficiency of the team. So in this first question, number 1, you're going to be listing the team coordinator and confirm each of the coordinator's responsibilities. If the coordinator doesn't have any responsibilities above, has any additional responsibilities not above, please ensure to describe those. One thing I want to emphasize here is that in each of these sections, if there is a bulleted list, make sure to answer all the questions on the list, not just the first several bullets. Questions 3 and 4 ask you to identify who your team leader or director is, as well as to confirm the team leader's responsibilities. Again, any bullet point that is not checked should be addressed in the following question, or make sure to answer or to confirm all the bullet points within each question. Again, if there are any responsibilities not listed above, please describe those additional responsibilities in the next section. Questions 5 through 7 ask you to identify the core team members that make up your cleft or craniofacial or cross-specialty team. ACPA Standards of Care identifies the core team as including speech-language pathology, orthodontics, and a surgical specialty. Again, this is how ACPA defines the core team members. Your individual healthcare team might define your core team member, for example, adding additional medical specialties or providers such as social work, nursing, dentistry, psychology, or social work. But keep in mind that your application reflects the ACPA's definition of a core team according to the standards. Again, that includes speech-language pathology, orthodontics, and surgical specialties. So in questions 5 through 7, you're asked to submit the information for your core team members, including their contact information for the lead member of each core specialty, who will also then need to submit a digital signature verifying that they serve as a regular member of the team and the application in their specialty is accurate. You can also add additional team members. So for example, if you have multiple speech-language pathologists, multiple orthodontists, or multiple surgical specialties, you would list them here in questions 5 through 7. We do require valid emails for each team member. As you're entering the team members, make sure that you scroll all the way to the right within the table to ensure that information isn't missed. Again, make sure to include all education and training that's relevant to cleft and craniofacial care for each of your specialty leads. The core specialty leads, again, will need to submit a signature so they can be added as a collaborator on the application. Instructions on how to add a collaborator will be provided later in the presentation. Question 8 asks for additional detail about your surgeon who is trained in intracranial craniomaxillofacial surgery. So this is for teams that are applying as either a craniofacial team or a cross-specialty team. When you're entering the craniofacial surgeon's qualifications, be sure to include craniofacial specific training, such as that they completed a craniofacial fellowship or where that fellowship was. Again, that person will need to submit a digital signature that verifies they serve as a regular member of the team. Again, you can also enter additional team members, craniofacial surgeons, in this section. Question 9 and 10 ask you to identify additional professionals that are members of your team. Again, as I mentioned earlier, ACPA standards of care define the core team as the speech-language pathologist, the orthodontist, and the surgeon. Your team may also include some additional specialties such as nursing, anesthesiology, psychology, social work, audiology, genetics, as well as many of the other specialties listed here. In section or question 9 is where you're going to add these additional people. We do require valid emails for each team member or the referral that's listed. We ask you to again indicate whether that provider or entity is a regular team member or whether they are available by referral. One thing that has changed since the last application is that providing a specific name of a clinic or entity that provides a certain area of care is now acceptable. We know that there are some teams that have a rotating list of providers for referral. It is now okay to list the specific center or department. So, for example, if your team typically refers your patients to the genetics department, but not a specific geneticist, that is okay. Or if your team typically refers your patients to a neuropsychology department or a specific clinic, it is now acceptable to list that clinic or department rather than a specific provider. Again, this is a change from the prior application. Some team members may fit into multiple categories. If that is the case, be sure to re-enter their information within each designated section. So, for example, you might have nursing, who also provides feeding, growth, and nutrition supports, who may also provide information about sleep health or hygiene. Again, list those team members in multiple sections. The next standard, standard 2, involves the team meetings. Again, for the purposes of the standards of care, the team meeting is a regular interdisciplinary meeting that includes the core team and other team members that provide coordination and collaboration on patient care. Again, team meetings are the meeting among the multidisciplinary team members. This is not the clinic day when all patients are seen or some patients are seen by the core team members. Again, this question is asking about the team meeting where your team discusses all the patients that were seen. There's a later question that asks specifically about your clinic day or clinic procedures. Again, this question is asking about the team meetings where you discuss patients that were seen during your clinic day. Again, we're asking whether your team meetings are held on the same day as the evaluation, and if not, what is the typical interval between your team evaluation and team meeting? The interval should be within a reasonable time frame to ensure continuity of care. For example, you might say that it occurs the week after the patient visit. Next, we ask for some information about in what format team meetings are held. Again, at a minimum, the core team members should discuss each patient in real time and formulate an interdisciplinary treatment plan. Questions 13 and 14, again, are referring to the team meeting, not the team evaluation or clinic day. So we're asking you to explain how, if a core team member is unable to attend that meeting, who attends in that person's place? Your response should indicate there is a two-way communication between the missing team member and the broader team to ensure comprehensive treatment planning. For number 14, we want you to give us or describe your team's process for achieving consensus on treatment plans. So, for example, you might indicate that the team reviews the patient's information, shares their input, and talks through the best options. You then agree on a plan by working together and considering what's best for the patient, and notes are taken by the team coordinator, and then a team report is authored by the team leader. Questions 15 and 16 ask you to upload a team report for a patient with a cleft lip and palate diagnosis and/or a craniofacial diagnosis that documents the participation of a speech-language pathologist, surgeon, and orthodontists. Specifically for the craniofacial diagnosis, which applies to teams that are applying as craniofacial or cross-specialty teams, we have listed a number of acceptable craniofacial diagnoses that would be appropriate. Specific report requirements are on the next slide. As a reminder, this report should reflect the redaction of any PHI information. The team report must be a single document that identifies the participation from the core team members. Again, for the purposes of the standards of accreditation, the standards of approval, the core team members are the speech language pathologist, the surgeon, and the orthodontist. We're looking for information on documentation from those core team members, as well as the names and disciplines of additional providers who examined the patient. Other information might include the year of the evaluation, their age, diagnoses, treatment history or findings, and the recommendations of each provider who examined the patient. The year of the team meeting that generated the report, and the individuals who participated in the team meeting. We're looking for an overall team consensus recommendation and information about the person who generated the team report. While it may be medically appropriate at a specific team day or visit or clinic that a patient does not see the core specialties in the specific visit, do not choose that report for your submission. Again, choose a report that meets all the criteria or all the bullet points that are on this standard. Questions 17 and 18 ask you to explain your team's mechanism for referral to and communication with other professionals. Number 17 asks about how you refer patients to other providers outside of your team. And number 18 asks you to describe the process for exchanging information with outside entities. So for example, in number 17, you might indicate that your team members refer to medical providers outside of the team for specialty care, such as orthopedics to evaluate for a spinal anomaly or endocrinology for diabetes management. At the time of your team evaluation, consent for release of records is obtained, and the family may indicate who they want to receive the team evaluation. Families may be provided with a copy of the team report, which they're encouraged to share with other specialists or agencies as needed, and the team report is sent electronically to the patient's primary care provider if one's designated in your medical records system. Again, 18 describes the process for exchanging information with other entities such as schools, universities, or outside agencies, or other professionals involved in the welfare of the patient. So, for example, you might indicate that a consent for release of records is obtained for an outside agency, such as a school, in order to provide the team recommendations, such as specific speech goals or audiology recommendations for an IEP. During a CLEF team visit, any release of information might be signed or collected as it pertains to the patient's care outside of the clinic. So again, for example, a release of information will be completed for the patient's school speech therapist, if they have one, and then the team coordinator will fax that release to the external entity and request for communication between the team member and the provider at the school or local institution. Any written records might remain in your patient's chart in the medical record system in some fashion, such as being scanned into the record. Question 19 asks you to explain your team or patient evaluation and how regularly you are evaluating the patient intervals. This question is asking about your actual evaluation of the patient, meaning your clinic day. So we're asking you to explain what is the logistics for your clinic day, such as how frequently the clinic day occurs, how many patients are seen, and how patients are seen by each specialist. So for example, do your specialists rotate to each patient room, or does the patient go from room to room on the day of the evaluation? So for example, in answering this question, you might indicate that from birth through alveolar bone grafting completion, by aged 8 to 10, all patients receive an evaluation yearly. The patients rotate within the clinic to different rooms, and they're seen by the surgeon, the speech language pathologist, the ENT, the audiologist, and orthodontics. After age 8, intervals of your team evaluation may be determined by need and diagnosis, and patients may also see individual specialists as needed. Question 20 asks if patients have the opportunity to receive same-day face-to-face evaluations by the core team members, and if not, explain how the patients receive those necessary evaluations by the core team members within a close enough time frame to ensure quality and continuity of patient care. So for example, if your face-to-face evaluations do not occur on the same day, you must indicate how your team ensures that patients receive the multidisciplinary evaluation and integrate findings and recommendations from all disciplines. Evaluations should be within a close enough time frame that it's clear that all 3 core team members are evaluating the patient at the same stage. So, for example, in answering this question, you might indicate that the coordinator assigns appointments for the patient to see speech, surgery, and orthodontia within the same 30-day period, and then does a phone assessment to see if appointments for any other team specialists are indicated. Question 21 asks for your protocol and how often a team is evaluating a patient with a cleft lip and palate from birth to adulthood using the tables provided. Notice that we are now providing you with tables that break it down by life stage and then by the core specialties, rather than giving you an open space to provide this information. For this question, you'll enter all the data into the tables that are provided, and again, they're broken down by life stage and core specialty. We can also provide any further details about your protocol for evaluating a patient with a cleft lip and palate during a life stage that's not described above, but note that is an optional question. Question 22 applies to teams that have applied as craniofacial or cross-specialty teams. Similar to question 21, it asks you to tell us the protocol for how your team evaluates a patient with a craniofacial diagnosis from birth to adulthood. Like the previous question, you enter all the data in the tables that are provided, and you will be asked to list a specific craniofacial diagnosis to use as an example for completing the tables. Be sure that the responses are specific to a craniofacial diagnosis that's indicated. Question 23 and 24 ask about the central and shared records that your team uses. So do all your team members have access to the same medical record system and use it for patient documentation? And if not, how does the team ensure that that information makes it into the patient's medical record? So again, the team should have a mechanism for keeping records that all team members have access to. And if evaluations or treatments are performed by an outside referral, explain how that becomes part of the patient record. So, for example, you might indicate that the team requests a copy of the report from relevant evaluations conducted outside of the team setting. That report is then scanned into the patient's medical record, and relevant findings and recommendations are included in the patient abstracts drafted for team providers ahead of a team clinic visit, and then are summarized in the patient's team report. Standard 3 involves communication and how the team communicates with the patient and family and caregiver. Here we're asking you to provide information in questions 25, 26, and 27 about how information is provided to both the patient and the family. So for 25, we will ask you which team member is responsible for providing information about the patient evaluation and recommended treatments to patients and families. 26, how is information communicated to families orally? And in 27, how is written communication shared with patients and families? And what steps do you take to include that the summary is at an accessible reading level in your team reports? So for example, in answering question 26, you might say that each provider discusses recommendations orally during the team visit with each patient and family, and then the team coordinator reviews team recommendations for updates after the team conference and provides those updated recommendations orally by phone to the patient and family. For answering question 27, you might say that the written report includes all findings and recommendations, and it's shared with the family through your hospital's patient portal. The next section of Standard 3 asks about how you ensure that the patient and the family participate in the treatment process. So questions 28 and 29 ask how the team encourages family and caregivers to become active participants, and how the team supports families in discussing children's conditions with them and involve the patient as developmentally appropriate in your shared decision making. Again, we're looking for examples of how your team works to understand the patient's values or priorities to guide choices, as well as to address risks, benefits, or alternatives. So, for example, in 28, you should indicate how the family or caregiver is involved in decision making. You might indicate that families are actively engaged in shared decision making, with patients being engaged at their developmental level. You might indicate that patients and families are asked to identify their individual priorities for every clinic day, allowing the team to be sure to address the patient or family's priorities, which may or may not be the same as the team priorities. In answering question 29, you might indicate that all team members actively engage patients in a developmentally appropriate discussion, actively and intentionally create space for youth to develop their own values and priorities. If needed, team members may meet with patients and caregivers separately to allow more individualized discussion with patients. And when available, our team uses objective measures, such as neuropsychological or psychological assessments, to guide the approach the team takes in discussions with patients, ensuring that the discussions occur in a developmentally appropriate manner. The last part of Standard 3 involves financial assistance and how the team assists families or caregivers in locating appropriate resources as well as financial assistance. Again, we're looking for examples of financial resources that might be provided for families. So, in answering this question, you might indicate that teams ensure families are connected to state insurance plans, have copies of state laws related to cleft care coverage, and facilitate access to financial resources, such as EBT, transportation as part of their insurance, city plans, or local medical transport, food banks, housing assistance, or hospital-based programs, such as support for meals or parking. Standard 4 is the new standard that was not in the previous team standards of approval. This standards ask about how your team provides transition planning to all patients, either into adulthood or if the patients relocate. So questions 31 and 32 ask you to identify a specific team member or members who are responsible for coordinating that transition of care and describe your process for transition of care due to either relocation or reaching adulthood. So, for example, in answering question 32, you might indicate that at age 12, transition to adult care begins with a discussion with the family. Families might be provided with recommendations for adult primary care or adult dental care. The surgical, orthodontic, speech, and ENT providers may also provide specific names or contact information to providers who provide adult care. You might also provide resources for special needs patients. You might indicate that your team will transition patients out of team care by age 21, but specific team members may be available as needed. Information might include a team report that has a summary of all completed procedures and surgeries, the most current team findings and recommendations, including recommendations for ongoing low care due to relocation or transition to adult care. I want to emphasize that this question is asking both about adult transition care or if patients are transitioning to another location, meaning relocation. So again, if your team continues to provide care for adults, you might answer these questions by indicating how your team might plan if a patient is moving to another location. Questions 33 and 34 ask you to tell us how your team builds the healthcare management skills starting in the early adolescence years, and how the team supports those patients who are entering adulthood or helping the families of patients with cognitive or learning delays impact their ability to manage care as adults. So, for example, in answering question 33, you might indicate that your team takes a developmental approach to care, with later adolescents taking more of an active role in their care, such as answering questions from the providers first. You might indicate that necessary health management tasks, such as calling to schedule an appointment, responding to MyStart messages, are assessed, discussed, and practiced in clinic. In addition, team members might help patients practice giving their own medical history, as well as how to access and understand their team reports. You might indicate that your genetic counselor offers a meeting with all 16 to 18-year-old patients to review the genetic components of their cleft, as well as to discuss any reproductive concerns. In answering question 34, you might indicate that your team addresses the needs of individuals with cognitive or learning delays in a variety of ways to ensure that the patient, the family, and the team have an accurate understanding of their cognitive functioning based on prior cognitive or neuropsychological testing at appropriate intervals. When appropriate, families might be supported in obtaining guardianship, power of attorney, or supportive decision-making agreements. You might indicate that education is provided to patients at their developmental level and that various strategies are used to ensure understanding, such as teach-back methods, pictures, or written information. Teams might facilitate connection to local, state, or federal resources for individuals with cognitive or learning delays, such as information about job training or placement, financial assistance, as well as day programs as appropriate. The last questions in Standard 4 ask you to tell us information about how you refer to adult healthcare providers to provide ongoing healthcare needs and also how you remain available for additional referrals across the lifespan. So here we ask you to tell us, does your institution recommend a transition from pediatric cleft or craniofacial care to adult care? Is there a specific age, or do your team members provide adult care? And if so, which team members provide adult care? For 37 and 38, We asked you to identify that the adult providers who provide ongoing care for adult patients, as well as to indicate if the team is available to consult with adult healthcare providers to assist with that continuity of care. So, for example, in answering questions 36 and 37, you might indicate that between team members and referred providers, the adult patient will still be receiving interdisciplinary care. For answering question 38, if the team is not available to consult with adult healthcare providers, you might indicate that because your team is available based at a children's hospital and do not typically treat adults, so at the team graduation or last team visit, around 17 to 19 years of age, patients are provided with a summary of their treatment history, as well as discipline-specific recommendations with an emphasis on cleft-related needs that need to be addressed in adulthood. It might contain information about how to obtain adult services for each discipline, and that patients and families are encouraged to contact the team coordinator at any time if they need any adult referrals in any specific discipline. Standard 5 involves social drivers of health and how your team demonstrates sensitivity to individual differences that might affect the relationship between the team and the patient and family caregivers. So questions 39, 40, and 41 ask you to provide information about how you provide appropriate accommodations for parents with a variety of differing backgrounds, translation and interpretive services that are available, as well as what regular training is provided to team members in addressing social drivers of health. So, for example, in answering question 39, you might indicate that your team uses professional medical interpreters for any patient where English is not their primary language. You might indicate that you do your best to obtain hospital improved in-person interpreters and use virtual medical interpreters when necessary, and that children or other family members are not allowed to interpret for their caregivers. You might indicate that you ask standard questions about additional factors such as gender or sexual orientation and best to understand your patients and families, and utilize inclusive language in discussion or forums. You might say that you specifically ask families to share any specific cultural or religious beliefs, as well as to provide information on how to address potential barriers to care, such as social determinants of health, access to transportation, or financial assistance programs. And you might use teach-back methods to ensure understanding across family members. You might also provide accommodations such as larger rooms for those individuals in wheelchairs or with limited mobility. Again, in answering questions 40 and 41, you might indicate that your team uses interpreters and translated materials. And in answering 41, you might indicate that your team has an annual mandatory institutional sensitivity or diversity or cultural aspect training. Standard 5 asks how your team ensures that they treat patients and families in a non-discriminatory manner. Are they provided materials or references to the website, such as a patient's bill of rights or institutional literature? Standard 6 involves a mechanism for screening of psychological and social needs of patients, families, and caregivers, and to provide or refer for treatment as necessary. In answering question 43, the team should indicate what specific team member is responsible for identifying emotional or behavioral issues and that person's qualification. Please note that a statement that all team members may identify and recommend evaluation for psychosocial issues is not acceptable or compliant. There must be an identified individual who screens for this in a regular and systematic manner. For answering question 44, indicate if your team uses interviews or screening questionnaires to help identify psychosocial concerns. And if not, tell us about the process that you use to identify specific psychosocial concerns. So, for example, in answering question number 44, if you don't use interviews or screening questionnaires, you might indicate that your nurse screens all families by chart review to follow up on previously identified concerns by families or team members, such as a speech language pathology note indicating if an IEP is or questioning if an IEP is meeting a child's needs, or the patient and nurse ask all patients and families if they have any concerns or questions about their child's behavior, social, academic, or other related areas and would like to meet with a psychologist or social worker. For question 45, again, we want you to list a specific team member or referrals, which again could be a clinic or department, that's qualified to evaluate and treat psychological and social needs of patients. That person must have a team, so teams must have a team member or a referral who's qualified to evaluate and treat those needs. Again, the person who is listed for question 45, again, this can be an individual provider, a clinic, an entity or department, should also be listed in the roster from Standard 1. Standard 6 also asks if your team has a mechanism to monitor cognitive, developmental, and learning abilities, as well as educational services, and how you provide or refer for assessment and educational advocacy as needed. Like the previous section, questions 46 asks you to identify a specific team member who's responsible for monitoring cognitive development, learning abilities, or educational services throughout development. Again, a statement that all team members may identify and recommend evaluations for cognitive or learning issues is not acceptable or compliant. There must be identified individual who screens for this in a regular and systematic manner. Again, in answering question 47, tell us which team members or providers or entities are qualified to evaluate and treat neurodevelopment or cognitive issues. Again, these individuals should be listed in the roster from Standard 1. And then in 48, please tell us about your process for either conducting or referring for assessments of cognitive, developmental, and learning disabilities at appropriate time intervals. This can include assessments that are completed through early intervention programs or through the local school district as part of an IEP. So, for example, in answering question 48, you might indicate that team patients are referred for cognitive and neuropsychological testing through the hospital system or a local clinic in the community if their geographic area makes traveling to the hospital a burden. The team psychologist may review these outside testing reports and then is available for class-specific consultation with community providers as needed. Or you might indicate that the team psychologist and speech-language pathologist review IEPs and make additional recommendations regarding specific interventions or additional evaluations as needed. Question 49 asks how your team supports educational advocacy to ensure that patients are receiving appropriate educational needs from infancy throughout adolescence. So, for example, in answering question 49, you might indicate that your team supports advocacy in a variety of ways, such as by IEPs being reviewed by relevant team members, such as the speech language pathologist, psychologist, geneticist, or pediatrician. You might indicate that your team members write letters advocating for appropriate services based on federal law with recommendations for specific placements, services, accommodations, or treatments. You might also indicate that your team provides families with handouts on how to advocate for a Section 504 plan, IEP, or other school-based supports, and review timelines for IEPs, evaluations, meetings, and amendments. The last standard involves outcome assessments. In this standard, we're asking you to tell us about how your team measures and reviews outcomes at regular intervals. So, for example, for question 50, does your team have a structured process to evaluate its own performance to ensure that care aligns with established timelines, evidence-based practices, and benchmarks? If you do, please tell us about that process and explain and give us an example of how you review, document, and monitor the evaluation activities drawn from the parameters of care. If you don't currently have a structured process, please tell us about your plan for implementing this process, including a timeline for implementation within the next 12 months. That planned process should include information about how you review, document, and monitor evaluation activities drawn from the parameters of care. Again, for answering question 50, this process should be specific to your team as a whole and not the institution or an individual team members. So, for example, you might include regular systematic assessment of patient satisfaction scores, team process improvement projects, and meetings, as well as regular and systematic review of patient-reported outcomes. Questions 51 and 52 ask about how your team gets information from patient and families about their satisfaction and feedback based on the team's care. For answering question 51, for example, you might describe a survey that you conducted by the team to assess patient and family satisfaction. In question 52, we want you to provide us an example of how you improved either coordination of care, communication, or overall patient experience based on patient and family feedback. Again, please give us an example of the way that you improved care. In answering question 52, for example, you might indicate that your team has quarterly meetings to review any safety events, as well as patient and family feedback gathered by the hospital as part of all clinics. In those meetings, you discuss what you can improve based on the input of patient and family experiences. For example, you received feedback that the wait times were too long at the start of the team visits as families were being checked in, and so you instituted a staggered arrival schedule to space out the time for the check-in processes, such as filling out insurance paperwork, patient portal forms, vitals, and photos to reduce the wait line. times. You then reviewed additional feedback in subsequent meetings about wait times and further refined your process by splitting some of the initial check-in steps to be done during wait times between providers rather than all at the start of the team clinic day. Positive feedback was received from families after those changes were made based on written or oral information. The last part of Section 7 asks you to tell us about a mechanism that your team implemented around quality improvement. So, for example, how frequently does the team meet to discuss findings from clinical outcomes? And in 54, give us an example of how the team worked together to identify improvement priorities. Again, for number 54, your response should describe how the potential improvement was identified, how the innovation was planned, and how the result is assessed. Who participates in that process, and how was the entire team kept informed about the quality improvement process? The last sections of the team approval application ask you to have the team leader or director sign. This person must be listed as the team leader or director in Standard 1. We will not accept missing or incorrect signatures. The team leader or director should read the application in its entirety before signing the document. If the person who completes the application is not the team leader, the leader will be needed to add as a collaborator. You can add a person as a collaborator by going back into your application, clicking on Add Collaborator, and then entering the team leader's email. That person will then receive an email from the SurveyMonkey Apply system inviting them to collaborate on the application. The application also includes a signature from an authorized institutional officer. This is somebody who has fiduciary responsibility for the institution or practice that acknowledges and supports the operation of the team at this facility. Again, this person must have fiduciary responsibility for the team's institution. This person is typically somebody such as a chief executive officer, chief medical officer, dean of the medical school or college, or the owner of the practice in which the team operates. For this purpose, typically a department chair is not the appropriate person to sign as the authorized institutional officer. This form can either be signed through an electronic signature or an uploaded form. If you want that person to sign digitally, then the authorized institutional officer should be added as a collaborator. Alternatively, if you're going to upload the form, you must first download the form, have the person sign it, scan it, and then upload it through the system. Again, ACPA will not accept applications that are missing signatures or if the uploaded signature is not included with the form. Lastly, I would just want to go over some deadlines and additional information around submitting the application. The applications are due on July 15th, 2026. There is a non-refundable initial application fee of $375, which does count as the improved team's first-year listing fee. You can either pay by check or credit card by logging into the main ACPA website and selecting the ACPA store. You can mail checks to the ACPA national office if your institution would prefer to pay by check. Once your team has been approved as an ACPA approved team, you then need to submit annual self-audit reports that document your continuing compliance with ACPA standards of care. The self-audit report is an annual form that must be submitted and includes a team listing fee. Starting in 2027, that fee is $250. Once approved, teams are expected to attest annually to their continued compliance with the standards for approved teams. A self-audit is not required during the year that you initially apply for approval or reapply for approval. Again, the listing fee and application fees help offset the cost for administering the ACPA team approval program. If an approved team does not complete the self-audit report or pay the team listing fee by the set deadline, the team may lose its approval status. The self-audit report must be signed by the team leader and the coordinator, and the process is somewhat simpler than the initial application, and the commission only reviews it if there's missing information or a potential issue. Here's the timeline for the 2026 and 2027 team approval process. For teams that are applying for their initial approval or teams that are applying for reapproval, between now and July 15th, you can complete your application. Again, the deadline is July 15th. In August to October, the Commission will review those applications, and teams will be notified of their approval status typically in November. In January or February of 2027, ACPA will update the approved team listing on the website, and approved teams will receive toolkits. For teams who are already approved and submitting their self-audit report, that will be available sometime in August through October. And by late October, the self-audit reports and listing fees will be due to ACPA. Again, team listings are updated in January, and teams are notified of any issues in their self-audit reports. If you do need some additional information, we encourage you to review the Team Approval Procedures Manual and the standards for approval that are available on the ACPA website. As I mentioned, some of the information that I covered in this presentation is pulled from the sample application that is now available on the ACPA website. You can scan the QR code here to view the read-only sample application. If you do have any questions about the process or specific questions, you can contact the ACPA National Office, including Erin Brenneman, and either her email there or teams@acpacares.org. Thank you for joining our presentation today. We now have times for a few questions from teams if there are any questions. We do ask that you keep your questions generic and not specific to your team or your team's approval or process or application.
If you have any questions, you can either pop it in the chat or you can use the Q&A. All right, first question I see is, do the members who attended the team meeting post-conference need to be listed on the team reports?
So yes, you do want to list the team members that evaluated the patient, including their name or information and contact information in that team report.
All right, and the next question is, will there be more specific deadlines provided for the self-audit report in the future? So I can answer that one. Self-audit reports, so that after that first year, after you're approved, the self-audit reports typically open in mid to late August, and they're usually due on the last business day of October. And we do make sure to communicate all that information to our approved teams when they become available. Next question is, how can I access my application to renew? So if you have not started the application already, you'll have to start a brand new application. It is not linked to your self-audit report from the previous year because that's considered part of your previous application cycle. So if you haven't started already, just start a brand new application and that will start everything over. Okay, I think this is follow up to a previous question. It said, for example, the members who evaluated the patients are listed in our team reports, but do I also need to say who specifically attended the team conference?
So the team report should include the person who actually evaluated the patient on the day of your clinic, or if it doesn't occur on the same day when that occurred. It does not indicate that you need to include who specifically attends the team conference unless a specific member is not available, in which case you're supposed to indicate how there is a two-way communication between the missing member from the team meeting who saw the patient during the team evaluation.
Next question was, if your team is due to renew in 2027, do we submit this team report this year by July 15th or July 15th, 2027? So if you're up for renewal, renewal goes by calendar year. So your expiration date for your team approval is always going to be on December 31st. So in that case, if it's December 31st, 2027, then you would need to reapply for full approval in 2027. So then in that case, this year, you would just need to submit the self-audit report in the fall. So I think I see another question about if you're already approved team, then do you need to do anything for the deadline in July? So if you're already approved team and you're not, your expiration date is not in 2026, then you do not need to submit anything this year, just the self-audit report.
And then, Aaron, there was a question in the Q&A. Can you adjust and add members or processes within the approval year, or is it recommended to wait for your renewal?
So when it comes to if you're changing your team members, which we know that team members frequently change throughout the year, as you might hire new people or other people leave. That's a good opportunity when you submit the self-audit report to indicate any changes. When we do the self-audit report, you'll be asked to recomplete that team roster that you see in the standard one. So just make sure to note any changes. When you do the self-report, we do ask, if there's any significant changes or if you're not in compliance with any of the standards that you need to explain it and give us a timeline on when you're getting back into meeting the standards. If there's any concerns that you're not meeting the standards in the self-audit report, it will get flagged and reviewed by the commission, which may follow up with you. So do make sure that you indicate any major processes that within that approval you're in the self-audit report, um, rather than wait for the actual full application to renew. If there's not really any, if there's changes that really don't impact whether you meet the standards, you don't necessarily need to report those. I see. Where would we find out our expiration date? If you're not sure, I know that we send out those notification letters to teams that are approved and the certificates that indicate the expiration date. But if you don't have that information on hand, please just email teams@acpacares.org and we can help make sure that you know when your expiration date is. All right, and I see after you're an approved team, then you just submit a yearly self-audit report. So you would submit that for, again, you would not need to do that for the year that you're going through the approval. So the first year is covered. And then for the additional next 4 years, you would submit the self-audit report. But as a reminder, team approval is good for 5 years. So once your approval expires, then you have to reapply for approval. I see someone said that they're not able to view the QR code. Uh, If it's not working for you, I would try just going onto our website under the team approval section, under team applications. We do have a link to it, and it should work there. And if for any reason you're still having trouble viewing it, you can email teams@acpacares.org. Any other questions? Well, thank you everyone for attending tonight's information session. Again, if you do have any lingering questions after this session ends, please contact us at teams@acpacares.org. Ari, would you like to share any closing statements?
No, I just wanted to thank the folks who joined us or the folks who are watching this recording later for getting more information and learning more information about the ACPA approval process. Um, Good luck in your application process, and I look forward to reading your applications in the coming year.
All right. Thank you, everyone, and have a good evening.